Hey gang, Matthew Holt here, and welcome to the very first week of the Psychiatry Rotation QCOM MS3 vlog. I'm excited to be with you today, recapping my very first week on rotation and my very first week in psychiatry. So let me tell you one thing, this thing has been a whirlwind, I kid you not. It's been like, when the baby eagles get dropped out of the nest and they're just expected to fly. That's exactly what it felt like. And it just showed me how much I have to learn and how far we have to come. I was working with two other students this week over at Woodridge, our psychiatric hospital. I was working with Nathan and Hannah, and they were so great to work with this week. We're all just fumbling through it together, learning as quickly as we can, trying to make ourselves useful. It was pretty amazing. It was pretty great way to start, honestly, third year being in psychiatry, because there were bipolar patients, there were borderline patients, there were just major schizophrenic patients, all kinds of different things that we got to really piece together throughout the week whenever you see a patient and they are not telling you the truth, and you just you're too naive to really be able to tell the difference. So that was one of the things we got to kind of fumble through this week. And another thing is, whenever you're working with psychiatric patients, there has to be so much empathy, because these patients have been through so much in their lives. Life has dealt them circumstances that they could not necessarily change or had no control over, and this is the hand they were dealt. And so it's crucial to be, patient-centered and to be empathic whenever you're working with psychiatric patients. And that's one thing that I learned this week. So to kind of walk you through the week concisely, it's a Friday evening. Concisely, on Monday we did a lecture, just kind of getting us oriented. Dr. Bird, the clerkship director, kind of filled us in on what we were going to be expected to do over the next few weeks. We had some, intro to mental status exam, kind of like walking us through those things, and that was really good, crucial for what we're going to be doing. It was a great way to ease us into it. And then Tuesday morning, we were just thrown into our rotations, and we showed up, and we were working with two of the psychiatry residents, Dr. Jabbar and Dr. Roby. Talk about just great examples of strong women in medicine. They shined. We got to be with them all week, and just they have a way about them that they know how to deal with the patients they encounter each day, and it was inspiring for me. I was just thinking, wow, one day I want to be like that. I want to be able to handle any situation, and I want to be able to think through the things they had to think through as quickly as they did it. Our attending, Dr. Kendall, he's like a psychopharmacology wizard. I don't even know how to explain it. He did a fellowship at Yale in psychopharmacology. He worked in Asia for a year or two in research, and he basically is very progressive with how he kind of thinks about psychiatry in the field, and that was crucial. And it was great. He brought us lunch one day. You can't get any better than that. When your attending brings you lunch, and it might just be like, all right, this is going to be a working lunch, maybe, guys. So that's kind of how it was. So, we did it this week. We just grinded through it. On Wednesday, each of us got our first patients. We had to show up an hour earlier to kind of see the patient. And I'll never forget my first patient. I was trying to work on with a psychiatric patient who's just been committed. It's really a challenge to get. It's not like your normal patient where, what is your chief complaint? I have a cough. Okay, let's talk about. It's like, what is your chief complaint? And they just break down crying on you, which is what happened to me. And so, talk about fumbling through something. Talk about being a baby eagle just trying to flap. So that happened. And my first patient actually was in what they call a catatonic state. Go look it up. It was really quite interesting. And then, just to be able to, we have to look at the chart, and then we go out and we try to collect our H&P, history and physical, and report back. And so actually today I got my second patient and got to present that patient. And this patient was a little bit easier to work with, but it was a classic example of a patient who the subjective does not line up with the objective sort of findings that we have in the computer system. So that means either something's missing here, or somebody's lying about something, or it was just one of those situations where the just how naive I am as a third year medical student was just smacking me in the face. Like, I don't know what to think of this. And that's where the residents and attending just had to gather around and teach and show us the way. So that was kind of amazing to get to work through that. And I'll work through that. I'm sure it'll happen a lot over my career where the patient doesn't necessarily tell me things that are lining up with reality or the truth. And so that was an experience for me today. Also, to kind of give you a rundown of how it works, at least in Woodridge where I'm at, we try to show up around 7 and see our first patient. If it's a new patient that's brought in, we'll be the first to see them. We'll do an H&P, hopefully before they have breakfast at 7:20. And then we can kind of look more up and write our SOAP note. And then at 8:30, we have a team meeting where the residents, the attending, and all of the team members, there's therapists, social workers, discharge planners, pharmacists, the whole team's there in a room, and they basically go down the list. There's a patient census that has each patient that's admitted. I think it's something like a 24-bed wing unit, and they just talk through each patient and start the day. And then all the med students and residents and the attending get together, and we just see patients one at a time in the room and talk about certain cases. And there's a huge priority on the discharge planning. That's something you start from the very beginning, see it all the way through, because the whole goal of psychiatric care, at least inpatient, it seems like, is just patient comes in sick, we help patient get better, and we want to get patient out, because there was something like over a 40 patient wait list to get a bed in this hospital. So if there's psychiatric patients in the ERs all over the place, and there's not a place for them, they just have to hang out there until they can get a slot in the psychiatric hospital. So it's really important to treat the patients the best that we can and see them into the next phase of their life. So it was pretty amazing getting to kind of be a part of this atmosphere. It's been wild, to say the least. We've been working with patients that have conditions like bipolar disorder, borderline personality disorder, substance abuse problems. There have been complicated patients that have just, really challenging to work with in a unit where there's so many patients dealing with things like depression, suicidality. I mean, we've seen it all. In the very first week, today there was a schizophrenic patient, and this patient was saying some really off the wall things, like didn't even make sense. Like, it's so amazing. Like, so why are you here today? And they answered, well, my daughter dropped me off because she was going to the beach, and I'm here to get a suntan. And this is her story, and she believed it, and she was sticking to it. She's there to get a suntan. And so just amazing findings. And the residents told me, like, you'll really understand just how important psychiatric care is whenever you see a patient that's telling you they're there to get a suntan on day one. Get started on a medication regimen that fits their diagnosis, and then like 5 or 10 days later, they're, coherent and perfectly normal. And so it's amazing to watch how modern medicine can really help some disastrous diseases. And so that's what I've been seeing on psychiatry so far. Today we got to do our MOCAs. That's the Montreal Cognitive Assessment. So I kind of got to fumble through that. It's like a one-page document that basically, actually, I might be able to pull one out real quick here. Check this out. So this is what a MOCA looks like. All right, and this is basically a cognitive assessment tool that we use. Different things like trace a pattern here. What is this animal? What is this animal? And then recall these words, different things like that. And it's basically like you can get 30 points. And I think something like below 26 meets criteria for certain forms of dementia. And so we learned how to do that. We had to fumble through it. We sat with our patient, and it took about 15, 20 minutes this evening to kind of work through that with the patient. But it's crucial skills, learning to do it, getting comfortable doing it. So that's one of the cooler things that I got to do today and this past week. So the way it works, I had one orientation day Monday, 2 patient days, Tuesday and Wednesday. Thursday was half patient day, half didactic. So we still have lectures, right? So we actually got a lecture from Dr. Bird about child psychiatry. And then after that, we also got a lecture from a doctor who was actually just video calling in. He gave a lecture from India, right? And for him, it was like midnight. And for us, it was like, 2 in the afternoon. But he actually video called in to teach us about neurocognitive disorders, how to diagnose dementia, how to diagnose whether it's major or minor, all the qualifiers. And so this has been great. Like, honestly, this week has been amazing. It's good to be in this transition. My MPH classes are in full swing. I've got 2 of them, and I'm like when I get home, I don't even go home. I just go straight to the medical library. And after we get off the rotation on, I guess it was Wednesday and Thursday, both, we got out at 3:30 p.m., which was good for me because I had to go do the MPH work. That's not typical, I don't think, but it was good for me. And so this week, it's just been great. It's been encouraging getting to, figure all these things out. I had to buy UWorld. So UWorld for step 2 clinical knowledge portion for a Q bank that I will use for 1 year plus 2 practice tests. It cost $479. That was really bad for my bank account and the debt that I'm taking on from med school. That was not something I expected. I thought maybe $150 for the Q bank. No, $479, which was amazing. There's also a book series called Case Files that a friend of mine, Nathan, got this week, and I was checking that out today at lunch. And it looks like that's how we're going to learn. That's how we're going to get prepared for the shelf. So it's the big standardized final, 110 multiple choice questions we have at the end of each rotation to kind of see if we learned anything. So obviously I learned something this week, and if anything, it was I learned how to start flapping my wings. And every day is a new adventure, honestly, and it's so amazing to get to be doing this. So as always, see you next time.